Well, thank you very much, Colin, for those very kind remarks. And I'll give you your honorarium as soon as I finish uh, this talk. Aren't you guys nice for coming, and ladies for enjoying your lunch while we have a little bit of time to interact around a topic that I find to be interesting during the, what shall I say, playing the back nine of my career. It's hard to believe. Certainly when you're introduced to an audience like this and you hear various things, you must sometimes say to yourself, well, that was a former life. What are you doing now, so to speak? And I wanted to just share some things that I've been thinking about rather than to bring clinical coals to the Texas Heart Institute. Now, I have no disclosures related to this particular talk, but I'd like to begin with this rendition of space and time. Now, let's start as undifferentiated trainees at the base of the cone on the bottom of this particular slide. And we all enter into this cone as we go through our training, and we become fascinated with various aspects of medicine, science, education, policy, etc., to the point that we then begin to specialize, subspecialize, and sometimes super specialize. And we become experts in our field. And we develop these networks along the way that lead to other opportunities. And sometimes you come out on the other end of this particular narrow funnel and you enter into a different time during your career as you gain a little bit perspective, usually on the basis of the number of mistakes you've made during the early part of your career. And the end result here, of course, is that as your career continues to evolve, you may develop interests that you had never, ever had conceived of when you were during training. But the means by which to get there usually requires that you become expert in one aspect of what it is that you do to the extent that you are able then to collaborate with others and move forward. So this, of course, is quite topical, isn't it? So you're aware of the neutrino that was detected on the floor of the Mediterranean Sea 2 years ago in 2023, and then reported just this week in Science. The most energetic particle ever captured here on Earth. This is a neutrino from outer space, if you can believe this. This is not Star Trek, right? So this, of course, is the footprint of this neutrino traveling at ungodly speeds through the Mediterranean and detected by these various light detectors on the seabed a few miles apart. And this, of course, is then the physical embellishment, not necessarily an embellishment, but the physical rendition of what it is that theoretical thinkers like Einstein and others had actually posited about what happens when two hydrogen atoms collide and you can't account for all of the energy following the collision. So it's happening in real time. And I found this to be quite interesting. Again, on the outer aspects of one's career development. So if you're like me, this is how you wake up most mornings and make your way to work, right? So you think about putting a coat on, but in New England, of course, it's much colder than it is here. You put layers on, and then when you lose your hair, you put a layer on your head as well, right? And you want to make your way to work without anybody talking to you, right? You don't necessarily want to listen to NPR anymore because it's all bad news, right? And then by the time you open the door to your office, you're sort of downtrodden and you're not really energized for the day. And then, of course, once you begin to turn things on, like your computer, the last thing you want to see is that your inbox has been filled again overnight, and that you spend each and every day completely inundated by sensory information, and you're being required, of course, to filter the sensory information so that you can be productive in what it is you're doing. This is sort of like medicine in a nutshell, isn't it? Where knowledge is expanding so rapidly and at such an incredibly accelerated pace, it's not possible to assimilate all of those points of interest that you could potentially conceive of. And you have to learn how it is to filter what it is that you want to do in order to apply it to a patient or to apply it to a scientific problem. This, I think, is the greatest challenge of training and development currently. There is simply way too much. What's important? What's less important? 150 treadmill tests or 200 left heart catheterizations, it seems relatively concrete, doesn't it? When you're interacting with all of this other information that's coming at you about artificial intelligence and those things that are surrounding us. So some people ask, well, what is it like to be a general cardiologist? And of course, when you get to be a certain age, folks look at you that don't know you and say, well, you are obviously hatched right out of Hollywood, and you knew when you were a high school student that you wanted to become a doctor, and then you knew exactly once you started your internship what kind of doctor you wanted to be. Now, can anybody relate to that particular phenotype in the audience? Of course not, right? We're not hatched. We don't really know. And sometimes you take on different jobs like shining shoes or cleaning sand traps at various locations along life. So you come up with a big idea, someone gives you a bunch of money and you're an overnight success. You know anybody whose career pathway has been linear to this extent? You pick them out, right? And then make sure that you can try to grab onto the star. This is really what it looks like, doesn't it? Right? So you have an idea, you start something, you fail, right? And then you try to massage the idea that you had, you refine the questions, you gather additional resources to answer it, and then you fail some more. You don't get the grant that you've written, or you're a little bit late with trying to prevent somebody from having a complication of a disease that you've been following for a long period of time. You may have missed a clue. Right. And you learn from that and you apply it as you go forward. And then, of course, you seem like success at the end of the day to everyone who's been not involved with the fact that you've made a lot of mistakes along the way. So this is now my obligation to the cardiovascular community. And I think Dr. Rogers can identify with this, is that we're in a position to share the mistakes that we've made. So hopefully you won't make them. But don't for 1 second think that our career pathways were linear. And they're at least as convoluted as those that you think you've initially embarked on. So here's my definition of a general cardiologist. Does anybody in the audience wish to be a general cardiologist? Couple, right? So there we are, you know, on a scale of 0 to 100, maybe 2% of people, right? And I'm making a joke of myself, of course, because most nowadays would be an electrophysiologist or an imager or a heart failure person or an amyloid person or a right ventricular person or some combination of that. So it gets very, I think, challenging to maintain some sort of equilibrium in the super specialization ecosystem in which we all work, right? So when people have various questions, they say, well, and atrial fibrillation, you should see an electrophysiologist. Okay. And, you know, it's kind of a common arrhythmia. I think it's highly prevalent. Maybe we should know something about it. But my take-home message here is that we're currently not quite a jack of all trades nor a master of any one. It's the sort of utility infielder that the Red Sox recently then were able to sign away from the Houston Astros, right? And Bregman, who apparently is able to play second base in addition to third base, right, where he's going to be plugged in. And this particular image is near and dear to my heart, having grown up as somebody who competed at baseball and I'm in the same lineage as the older Mr. Bush, who preceded me by nearly 30 years in college. So here's where I am in the 21st century. So I came along in the 1970s, trained, did as many cases as I could, wanted to do more cases than anybody else in my fellowship group, just taking care of as many people as I could, working Saturday mornings, and then suddenly came to the realization, how should I prepare myself as a cardiologist in the 21st century, taking patients going forward? So it's not about end-stage aortic disease or aortic valve disease for every patient who walks in your office. It's a lot about being out ahead. So I think I need to know something about genes. Patients are asking about genes and should I have genetic testing, for example. I have a second cousin who also has a thick heart, or wearable devices whereby people can actually give you physiologic information about how it is they're doing rather than to rely on the history, which is oftentimes inaccurate. And imaging, of course, we talked about this morning among the fellows, it's really where it's at, isn't it? and artificial intelligence, which scares all of us, wanting to understand whether it's actually valid and can be externally applied to other populations. So this, of course, should enable us to be better at prediction, diagnosis, treatment, and prevention. And this, I hope, is the future that the young people here in the audience will inherit. I do want you to become better at prediction, diagnosis, treatment, and prevention. And you have some tools here that we never even saw on the horizon that may actually enable that particular dream to come true. This is a very exciting time to be in cardiovascular medicine and science, whether you're just starting or whether you're just finishing. It's a very interesting time. So here are some of the tools I think we need in order to navigate this space effectively as clinicians and as educators and as scientists. We need to understand genetics, omics, and systems biology. Think of that. Think about systems biology from a general cardiology perspective. We usually want the bottom line, the conclusion of the abstract. You just read that conclusion because you're too busy to read everything else. We all do it. All right. Artificial intelligence I've talked on. I think you need to know a little bit something about statistics. We need to be able to hold ourselves to some standard as to whether or not something is believable or not believable, valid or invalid. And I think that comes with a lot of trial and error. Trial and study design are important because certainly the world of cardiac surgery has for decades relied on observational studies performed at single centers where outcomes are great. Does that necessarily mean they can be applied prospectively to other populations with other surgical operators? And is the same true in cardiology? We certainly have started down that road, but we do have the benefit of some randomized trials, which I think have taught us quite a bit. And then, of course, don't forget mentoring and role model, which is the secret sauce of any institution, especially one of this stature, where you're not born knowing how to do something. You're not hatched out of an egg that tells you exactly which linear pathway to follow. You have to be able to rely on people to coach you. But I think more importantly, you have to have the self-confidence to ask questions when you don't know. And there's no better reason for people to remain on a faculty in a place like this, but to hope that a person will knock on their door and ask them a question of that nature. Don't ever forget that. It's the secret sauce of a place like this. So here's a typical representation. What am I supposed to do with this information, I ask myself. What should I know about how information is collected from a group of patients that may eventually lead to new drug discovery? Because it is my hope that someday we're going to be able to give people a pill that reduces the rate of progression of various types of valvular heart disease, like aortic stenosis. Just think of it. All we do with aortic stenosis is watch it. And then we get really excited about intervention at the end stage of the disease. Think about that for a minute, right? Just think if we had the same approach to lipids, right? Or even various stages of heart failure. I think we need to know a little bit about this stuff. I think that there must be a pointer here, but if you were to look, for example, among a group of people that may or may not share the same phenotype, and you do some genotyping, and then of course you do some quality control because we're always criticized for the fact that we only do genotyping in select populations of white Caucasians who live in Western Europe. And nowadays, of course, we need to know a lot about people who self-identify as African or self-identify as Pacific Islander, et cetera. And so it's a very good idea to take some of these genetic observations and see whether they apply across different race and ethnicities. And then we do something that I really like, of course, is when the data are missing, you just impute it, right? So, of course, when you get stuck because you didn't measure every endpoint in a trial, you go through these statistical machinations that only our statistical colleague can understand about. I'm going to make up this number. It's somewhere between these two. We do that every day, don't we? Okay. And then we do some association testing. This is called a Manhattan plot, where you really look to see whether or not there's statistical significance of a genetic association with a certain outcome. And then you do a meta-analysis by making sure that this actually has applied across different trials. And then you try to replicate it in another cohort. And then you actually do another post-GWAS assessment to see if you can identify a protein target for an intervention. And then you display your data like this, which is, of course, a 1980 stereo, where you're trying to, you follow? This is a joke. Okay. Remember the stereos where you could kind of get the thing that go up and down? Well, that's what this is, but I put a little DNA on it to try to convince you I knew what I was talking about. Okay. All right. And if that's not the case, then at the end of the day, you can try to put all this information together. You're walking on the tightrope. And what do you want to be, right? You want to be an electrophysiologist. This is the brain of an electrophysiologist, right? So people that can understand math, science, physics, and everything all at the same time while they're doing a procedure. So that's the end game for all of you who are training. Try to be like an electrophysiologist. Okay, I think that's what they do. We don't see them, right? They're in the lab. All right. And if that's not enough, you display your data like this, a qualitative or quantitative trait locus. And this, of course, attempts to link certain traits with various single nucleotide polymorphisms that are displayed across the genome like this. And if that's not straightforward, you just do this network biology, and it just comes together really well, doesn't it? You sort of look at this and say, yeah, I can really intuitively feel where this is leading, right? So what's a general cardiologist supposed to do with this information? Number one, ask for help, right? Number two, of course, say, well, can somebody guide me through this and make sure? But it's okay if I try to develop some intuitive knowledge as to whether or not something is scientifically making sense, because after all, we are trained as scientists during various times. We just get distracted along the way because of clinical responsibilities. And then one of my favorites, Mendelian randomization, which I'm sure that Dr. Rogers knows a lot about, whereas if you can't do an experiment by gathering 100,000 people in order to test a drug outcome, you just do a Mendelian randomization where you assume that the alleles are randomly distributed at birth. And you have an exposure. Well, for example, you have this instrumental variable called G, which is usually perhaps a single nucleotide polymorphism, and an exposure and to see whether there's an outcome. But if you're not careful, there are all these red lines, which mean that there can be an end around. And you have not accounted for all of the confounding that may occur in the heuristic that you've developed. You can't read a journal article these days without finding some reference to Mendelian randomization. It's okay, I think, to get a little bit familiar with it, but not too much deep in the weeds. So let's take that as background, a little career development, a little sort of stress on the average cardiologist trying to make her or his way through the 21st century. And let's apply some of this to the stages of a patient journey with valvular heart disease. So at the onset, there's the screening and detection of valvular heart disease, right? We won't know it's there until we actually find it. And then we find it, of course, and then we need to assess it. And oftentimes that eventuates in referral. And then occasionally, of course, a treatment, which could be medical or it could be some kind of physical intervention. And then there's this stage called follow-up. So this looks very similar, doesn't it, to the stages of heart failure? I think they're changing all the time. Wasn't it a song? Changing all the time, right? But that was the lyric in the song, right? Remember that one? That's a Fleetwood Mac song? Yeah. Okay, great. Good. I'm glad you're with me. So this is where I was during my fellowship. And this is my fellowship director at the time, the late Peter Yurchak. And these are some windows at Mass General. We didn't, I guess, we imported this nun because the MGH was more of a kind of a different place at that time. In any case, the stethoscope was invented, wasn't it, in 1816? Just think about people listening for pulmonary sounds with their ears up against the chest of a patient. Think of that, right? How can you screen for anything with your ear? And the stethoscope was invented in part because of the modesty that certainly characterized the 19th century at that time, and the fact that all of the physicians were men at that time. And how is a man supposed to examine a woman in the early part of the 19th century? Well, you get a tube and try to listen that way. And that's part of how this all came to be. And then, of course, further refinements are made. So here we were screening for valvular heart disease with the ear or the stethoscope. How good is that? to say for the population of people that live in the city of Houston, right? Houston's the third largest city in the United States. Can you imagine going out to listen to everybody? And even if you could, you'd probably miss about 30% of the murmurs that are there. Think of that. Okay, so this, of course, has led many people over several years now to use artificial intelligence-enabled auscultation, where screening in general practice can actually be augmented with a 3-lead ECG and the use of an iPhone, and then a filtering mechanism, and then asking questions on a population basis. When the heart sounds are abnormal like this, what's the sensitivity and specificity of detecting valvular heart disease on the basis of the murmur heard? And the performance of these particular systems is actually spectacular. So if you were going to start a screening program for valvular heart disease because you're concerned that aortic stenosis is undertreated in the community, maybe you would use some of these AI tools, of course, and enhance the number of people that you could identify earlier. Or if you're really smart, you would simply do an ECG and you would ask the ECG with AI-enabled analysis to predict incident aortic stenosis, incident heart failure, or incident hypertension on the basis of an AI-enabled ECG analysis, oftentimes from a single lead. So there's a lot of work that's been done. Suffice it to say that some is good and some is better, but nothing thus far is excellent. And all of these training algorithms perform less well when they are undergoing external validation. However, I think it's fair to say there appears to be enough information in a simple ECG to actually predict onset of various cardiovascular diseases at a much earlier stage. Do we do this? Has this been scaled up? No. They do it at Mayo Clinic, actually. They now have an AI ECG-enabled pathway for every ECG of patients admitted to that particular institution. And this is a Mayo Clinic publication that is now several years old. So genotyping, I think, is where it's at. And this is a disease that's been quite interesting to me, namely calcific aortic stenosis. And it's been more than 10 years since this paper appeared in the New England Journal of Medicine that really taxed me as a general cardiologist to try to understand the methodology that these investigators used in order to make sense out of their observations. They used at least 6 or 7 different methodologies in this particular report, and I hadn't heard of half of them. So I think we can still learn by trying to read things in depth. But this is the Manhattan plot to which I referred to before. And certainly above this particular line, you can see that there's genome-wide significance for this single nucleotide polymorphism at the genetic site that dictates lipoprotein A. And this is now an old story, right? So this, of course, has led to numerous studies at a population level and actually at a subpopulation level that ties lipoprotein A to the development and progression of aortic stenosis over time, and has led to a lot of interest as whether or not this could be a reasonable target to identify that might lend itself to drug therapy and a slowing in the rate of progression of this disease. But actually, investigators have done the same for mitral valve disease. Here's another very interesting disease, mitral valve prolapse, that, of course, people have for a long time suspected a genetic origin, especially among families of patients with mitral valve prolapse, of which there actually are several. And here's a study from a couple of years ago in the European Heart Journal from MGH colleagues showing 7 different nucleotide polymorphisms associated with the development of mitral valve prolapse over time and the construction of something called a genetic risk score. And genetic risk scores are highly prevalent now. How should we filter them into routine clinical practice? Are they better than using your stethoscope and following somebody longitudinally? When it comes to things like a genetic risk score for coronary artery disease, is it better than just knowing what risk factors are for coronary disease? And that's kind of the level that we're at. So here are here are examples of several SNPs in the TGF-beta signaling arm, for example, and then cardiomyopathy, which Dr. Rogers knows quite a bit, that have been associated in a non-syndromic way with this particular phenotype. And then imaging, of course, is really everything that we make it out to be. And these are some MRI cardiac MRI examples of elevated T1 time here on the left. And then, as you can see here, late gadolinium enhancement in a patient with mitral valve prolapse in the lateral wall without epicardial coronary disease. Completely new phenotype to us over the course of the last decade. Maybe this underlies some of the arrhythmic mitral valve prolapse that we'll talk about. And I've already mentioned diagnostics. I would like to get smarter. So one day I'm going to buy smart glasses, a smart watch, a smart shirt. Think about that, and even smart shoes and socks. So if you can, link up with this kind of technology and buy these things on Amazon, sign me up, because then we could all get really smart. But obviously the idea here is that patients can tell us a lot with physiologic measurements. And how many folks come in and tell you that they're tired? What are you going to do with that information? Of course you're tired. You don't sleep well at night. You probably have sleep apnea, might have a little bit too much alcohol. You don't exercise, and blah, 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 et cetera. But occasionally somebody is tired and they have reduced cardiac output, for example, right? Or their cardiac output is becoming more reduced over time. And then point of care ultrasound, we talked a little bit about earlier this morning, the fact that this is being utilized routinely in most emergency departments and is now being taught, of course, in several medical schools, because the data would suggest that it's better than auscultation for the detection of pathologic heart murmurs. Not even close. Okay. And then imaging, which provides us with all of the insights that, not all of them, but most of the insights we need in order to make therapeutic decisions along the way. And these are several renditions, all in patients with aortic valve disease, with which you're very, very familiar. I like this particular heuristic about using phenogroups to detect outcomes in patients with certain types of valvular heart disease. And here, these investigators with Dr. Sengupta and others several years ago applied imaging information across 3 modalities to try to develop a risk scoring system as to who's at greatest risk for developing aortic stenosis that would come to replacement in the shortest period of time. And as you can see here, he was able to identify high severity versus low severity phenotypes of aortic stenosis based on echo, CT, and MR information. And we don't do this routinely. In an integrated way, at least results reporting. When patients have aortic stenosis, they come, they have a murmur, they have an EKG, an echo usually tells you everything you need, and then occasionally you do an exercise test. Well, the question, of course, is whether or not we should be using multimodality imaging more routinely than we do, and it would be attractive to think so if we could do so with fewer dollars expended in the process. And I mentioned before this high-risk subset of patients with arrhythmic mitral valve prolapse. These are folks who have sudden cardiac death or syncope, despite the fact that their mitral regurgitation is only moderate. So what's driving the train? And do you operate on moderate mitral regurgitation? Or is this really an arrhythmic substrate and you should ablate it? Or you should actually ablate it, put in a defibrillator, and operate on the patient. So for this particular class of patients, there's a lot of interest in many sites across the United States and Western Europe, trying to unravel some of these lovely biologic differences that distinguish these people, including this sharp systolic waveform. And then, as I mentioned before, this late gadolinium enhancement with fibrosis of the papillary muscles, as if there's this constant ischemic insult to the papillary muscles as the valve tenses posteriorly into the left atrium. And you have repeated injury, as if like it's a carpal tunnel syndrome in your papillary muscle. We had a patient recently on the service I was supervising and came in and had moderate mitral regurgitation with mitral valve prolapse and sudden death, from which he was successfully resuscitated by a bystander, which was really fabulous. And he had a cardiac MRI that said, this is where his VT must originate from. Okay, so it took him to the lab, everybody's geared up, and then turns out his VT was nowhere near his papillary muscles. His VT came from his tricuspid valve annulus. And then somebody, gee, I wonder how this happened. Well, let's go back and look at the original information. And then, of course, the original information suggested all along that he had a right ventricular cardiomyopathy and happened to have a mitral valve prolapse along the way. So, of course, you've seen one case of this, you've seen one case of this. And here are some additional pictures, but this is my favorite one. Characteristics of patients with arrhythmic mitral valve prolapse, including annular disjunction here, fibrosis, and also inflammation in these CMR PET fusion images. But here, I think, is the coup de grace, which shows very, very cleanly in this circulation report from several years ago, relationship between late gadolinium enhancement here in the lateral wall and the development of fibrosis on this trichrome stain, which is really very dramatic. So it does happen without epicardial CAD, just like it happens in aortic stenosis. And no talk nowadays, I think, for us is complete until we've at least mentioned the word CHIP, and this doesn't imply to people having complicated PCI. Right? So this applies to people who have somatic mutations as they age, sort of like me, right? So if you get enough somatic mutations, you might escape with leukemia, like CLL at late age, right? You get lesser numbers of mutations, and it appears as if some of these drivers, particularly TET2, associate with an excess risk of venous thromboembolism, atherosclerosis, and myocardial infarction. And so this interplay between aging, right, chronic diseases, atherosclerosis, inflammation is gaining increasing momentum. It's not to say that CHIP is a public health malady like hypertension might be, but there are people who are interested to try to democratize looking at these kinds of somatic mutations in larger numbers of adults who seem to get into trouble in their 70s and 80s. Interesting biology. I'm not sure exactly where it's going to land. And the molecular targets that can be detected or can be predicted on the basis of the information that I've shown you previously. This is the lipoprotein A molecule, which, as you know, interacts directly with its own receptor at the level of the nucleus, and then begins to instigate a variety of inflammatory changes within the interstitium of an aortic valve. So it basically leads to a phenotypic change of valvular interstitial cells, where they go from being quiescent to suddenly they go to laying down fibrotic matrix to then eventually bone protein matrix. And the next thing you know, you go through these stages of inflammation, fibrosis, and calcification. So really smart people, like those who work in the TIMI group with us up here in the upper right, looked at this retrospectively, making the observation that, yeah, we know these PCSK9 inhibitors actually can reduce the levels of lipoprotein A by about 20 to 30%. So why don't we look retrospectively to see whether patients with aortic stenosis who were exposed to a PCSK9 inhibitor during this randomized trial had lesser or fewer events related to their aortic valve over time. And this is a landmark analysis. So here at 1 year in the blue line, you can see thereafter that patients who were randomized to the evolocumab arm had fewer aortic stenosis events compared against those who were randomized to the placebo arm at time 0. And this has fed a lot of the kinds of trials that are currently being designed in this space. And this came out last night about an omics-guided discovery approach. And the only reason that I would bring this to your attention is that this is where our field is going. This is beyond sort of the echocardiographic parameters on which we lie. We've kind of gotten really good about recognizing things, and you reach this particular threshold, but we need to kind of go back in time and see if we can get onto the prevention aspects of things in so many words or less. And people are looking at mechanical forces and matrix turnover, to which I've referred, and the genomics and the proteomics, and a target identification for drug discovery. This is a wonderful review article, the senior author of which is a member of our faculty. So this is very exciting for me, and I wanted to kind of bring this into sharper focus. And this, I think, is what might happen with the kind of computational power that is currently available across many, many health systems. So what if we were to construct digital twins of ourselves or our patients and ask questions of the twin saying, if I perturbed your biosystems in this way, what would be the response? So for example, if I operated on you at time 0 versus say year 3, what kind of response would there be with regard to your myocardium, as regard to your longevity, et cetera. So constructions of digital twins may allow experiments using an N of 1 in ways that I certainly never considered. And here's a very nice example from a trial that we're doing at the CTSN, predicting the response to mitral clip versus surgical mitral valve repair in patients with degenerative MR. So this is a randomized trial into which we've now enrolled about 285 patients over a planned 450, and it's the clip versus repair. And of course, if you're a surgeon, you love this because you think you can outperform the clip every time you do a repair procedure. No question about that. And we're not specifying how the repair is done, and we're not specifying which device might be used. Now, this, of course, falls into that category of I'm showing this because I'm pretending I know what I'm talking about. Do you ever do that when you give a lecture? Okay. Sometimes you do, right? Okay. In any case, these are so-called Windkessel formulae. And these are formulae about flow and resistance in various circuits, like the pulmonary circuit or the systemic circuit. But the CMR folks who are collaborating with us in the network have actually used these to construct CMR avatars of hearts of patients prior to an intervention. So as part of the randomization process, that's great. And then we're going to try to do digital avatars of each of these and predict what we think should have been the response to the intervention to which the patients were assigned. So I think this will be very, I think, interesting. It's a sub-study. It may provide physiologic insights, but just think if you could share that kind of information with patients in the future. If I clip your valve and achieve this degree of reduction in mitral regurgitation, this is what we might expect. Not bad. Okay. And people are using this in electrophysiology, and this is an example of work that was done at Hopkins with my friend Hugh Calkins. And what he did was he studied a group of patients with a right ventricular arrhythmogenic cardiomyopathy. And here he mapped the circuit of the ventricular tachycardia in patients with ARVC. And here he used actually a cell model to actually predict what the circuit would be based on the genetic mutation contained in each of the cells, two different types, this elusive mutation versus a plakophilin mutation. And sure enough, these cellular-based gene mutations predicted with very high accuracy what would be the clinical circuit of the VT. So this, I think, is really very exciting. And for a place like this, of course, we can always think about making better valves in patients, for patients, so that they last longer and have fewer thrombogenic complications. And there's a lot of work with tissue engineering that has gone on. And this is the sort of place that has put lots of tissue engineering or mechanical support systems, et cetera, on the map. But people are working in cell-free scaffolds, believe that, right? And then implanting platelets and leukocytes, which then undergo a series of inflammation and tissue remodeling. The cells are digested, and the next thing you know, you get this kind of matrix formation that is non-immunogenic and less likely to clot when exposed to blood. Very exciting, and it may come to fruition. So, of course, the stages of the patient journey is what underlies the discussion today, and these are all familiar to you. I'm just trying to add a slightly different dimension to that space and time heuristic that we looked at the beginning of the talk. A follow-up, of course, is something about which we're all not very good. We have very little idea as to what the, quote, optimal medical therapy might be following a valve intervention, don't we? Patients after have TAVR, thank goodness, you know, everything went well, you're home, you should feel better. Well, they have thick hearts. They could have heart failure with preserved ejection fraction with or without aortic stenosis, atrial fibrillation, et cetera. So there's a whole frontier, I think, about which we need to apply ourselves more assiduously. And this is all about delivering on the promise of personalized medicine. This is all about, I think, expanding our toolkit in a way that we can apply to an individual patient in front of us, recognizing the variability in natural history, recognizing the social determinants of health that many times dictate outcomes. right? Many times dictate your ability to actually have an impact at various stages of the disease because it's hard to access medical care. It's hard to get a hold of medications. Certainly an SGLT2 inhibitor or a GLP-1 receptor analog, they're all the rage, aren't they? And they can be so expensive that people can't afford them, obviously. And not everybody gets a discount. So in addition to all of the fancy things that we've talked about, let's not forget about access and the social determinants of health that actually, I think, challenge us on a daily basis. So I'm going to end with some 5 attributes for the general cardiologist in the 21st century. I do think it's important for you, especially for those of you in training, to focus and to become expert in one area. You're going to expand as time goes on. And don't forget, integrate broadly right from the start. After all, you all went to fabulous universities. You became liberally educated along the way, and it hasn't been beaten out of you. I can guarantee you, it has not been beaten out of you. It's there. Remain inquisitive. If you're not inquisitive, time to hang up the cleats, right? That's when the world passes you by and you fall off that tightrope that I showed at the beginning of the talk. Know your limits. Yeah. Talk to somebody who knows about cardio-oncology. When somebody develops heart failure after exposure to 3 different types of agents, which one could it possibly be, right? I can always look it up, of course, but what does experience tell you? Don't stop learning, of course, and resilience helps along the way because none of us enjoys the sort of linear development of a career to which I referred initially. Thank you very much for your attention.